Right. Good morning, good afternoon, and good evening to you, wherever you are. We are here for our special session number 27 of the COVID-19 series, the series that we have dedicated to diagnostics in the COVID-19 pandemic. Today, we have a special topic that we probably taking for the first time, the issue of digital solutions to support our healthcare systems, and particularly how it has been applicable to the COVID-19 pandemic. We realize that as we try and find a solution to this pandemic, we have more and more alternatives coming through in terms of innovations and interventions that we need to put in place. But for these to be as effective as possible, we realize that technology, particularly digital technology, is something that we cannot leave behind. Hence, we saw it fit to be able to bring these on board and get a few samples of what is out there and how they have been used to fight the pandemic. In order to do this, we have called three of our providers of these services in the name SafeCare, SAVICS, as well as EdgeX, to share with us what they have in store and how it has been implemented. My name is Anafi Mataka, and I'm delighted to be your host today. Today's session will be slightly longer. It will be about 90 minutes long. We will have three of these presentations. We might take a few questions in between, and then we'll have a longer Q&A discussion at the end. Would like to start with our presenter from SafeCare. The name is Afke Dikaraf, to take us through the first presentation. As the presentation goes, as usual, keep your questions and comments coming through the chat box, and we shall take them as the session continues. Afke, over to you.
Thank you. Well, good afternoon, everybody, and good morning as well. I would like to tell you something about SafeCare for COVID app. And I would like to start with the problem we have experienced with our facilities and why we developed this tool. So, of course, COVID-19 with over 33 million confirmed cases and more than 1 million deaths. But what we found yet was that practical and easy to use information for healthcare providers about COVID-19 was missing in our network. And there was also, for our partners, a lack of data on the preparedness of supplies and processes to inform their decisions. So that's why we developed the SafeCare for COVID app. We have been working, of course, with a lot of healthcare providers before, and we wanted to help them with avoiding facility-based infections and spreading of COVID-19 by providing them this practical information, data and tools. And also to set up and maintain up-to-date processes and knowledge to manage not only COVID-19, but also in relation, of course, of non-COVID cases. And I would like to focus first on the two focus groups that are most important. Of course, the healthcare providers. We wanted to empower them with holistic information. And of course, this is a mainly a laboratory audience, but we thought a holistic app was important to also add management, clinical training and documentation information and knowledge. And we based it on WHO information and guidelines. Of course, the WHO is expert and evidence-based, but we thought for smaller facilities, more practical information and really focused at the basics was important. So we developed for them a supply checklist, a self-assessment on processes, a QIP based on the self-assessment that they performed, and supporting materials like posters to make it really as a direct check and information. And I will, in a moment, I give a demo to show how the app works. But what we also found out was that our partner organizations would also like to have this information for allocation of supplies, input for training and capacity building. So they could use it both. So it could be an app that could be solely focused at healthcare providers, or be used by their network organizations as well. A brief introduction on who we are. Farm Access is an NGO that aims to increase access to better care, and usually through partnerships. And we have offices in 5 countries, in Nigeria, Kenya, Tanzania, and Ghana, and our head office is in the Netherlands. And within Farm Access, there are 3 focus areas, and the quality part, that's what SafeCare is. And SafeCare was developed 11 years ago together with JCI and COSASA, and provides not only standards of quality, but really focused on solutions and progression. And in that time period, we did more than, or almost 6,000 assessments. And to help those facilities, we first started at the beginning of this pandemic with on-site support. So we visited them, providing, as you see on the photo, posters to them, translating WHO documentation into nice visuals, and also translate them in other languages. But as the lockdowns started, we got a request, and also we thought it was very important to have this more this support that we could also give from in a remote way. So we really asked providers, what would you be using? What would be helpful for you? So we developed this really human-centered design. And as you can see, we developed already a lot of apps before that. But what we thought was very important in this is to develop it with input from behavioral experts, to really increase the value with, as you can see here, did you know questions that are really a call to action, and to adjust the mode of answering options to increase truthfulness. Well, let me start with showing you a very quick, usually the app takes you half an hour, and what you can see here is that you can access these supporting materials and posters. Of course, I did it now a little bit quicker because we don't want to sit here for 30 minutes looking for a demo. So you can see here, it's a combination of the onboarding questions, combination with the supply checklists, and the assessment questions that are really focused on processes. And what you can see here, if you answered all the self-assessment questions and the supplies, you can both download them, put them on your wall, and use the QIP. Like you can see now, you get a score. So that really is, of course, also a motivating factor, hopefully to increase your score. And you can see really the activities that you need to do precisely, and could check them to work on to improving your quality for caring for patients with COVID-19. Okay, this tool can also be, if you're a bigger organization, we can customize it so that, for example, this link will lead you to the link of your healthcare organization website. And we can also add logos to make it more, or to customize it. Okay, the app, you can see there on your screen, is worldwide accessible and free of charge, and you can access it by this URL. And currently, facilities in 19 countries have been using it, of which 15 in Africa, and more of 600 facilities registered yet. And we have started, so the number will increase with now 11 partner organizations to work on the app and using the dashboards. I thought this is really a technical audience to show you some of the questions that are involved in the app. And of course, I made the ones that were interesting for laboratory experts red here. So of course, the PPEs are important. For infection prevention, the questions, these are the questions of the supply checklist. And you can see, because it's a holistic approach, a holistic tool, that we also have questions about monitoring oxygen and advanced supplies. And there's, of course, the blood chemistry also included. For the processes, we have 31 questions, and they're structured in 4 categories: clinical management, infrastructure and supplies, capacity building, and infection prevention. And as you can see here, there are also questions that would be not only interesting for the whole hospital, but also for the laboratory, like the collection and referral of laboratory specimens, labeling of restricted areas, maintenance mechanisms, and again, IPC. This was, of course, the first focus group, the healthcare providers, and I thought it would be nice to show you some of the comments we had. So great inputs on the tool, and what I really thought was a nice quote: "I shall make good use of the app to keep improving quality-wise, for it's a space that never gets filled up." And the quote that I thought was most interesting is that they found the platform useful because it opened my eyes to some things I haven't put in place while I thought my facility was ready. Well, I think that was a great compliment. What I will share with you afterwards is now 2 slides of the dashboards that partner organizations could access, and that would be their personal dashboards. And then some learnings about of all the data that we have now. What you can see here is the more than 600 facilities that have registered. And if you have, if a partner organization uses their dashboard, they will only see the number of checklists and facilities that they're specific, that are done within their network. And they will have overview pages for the supplies and the capabilities, where they can see the per category how the supplies in this case are available. Of course, this is those percentages are only based on the applicable supplies. So what you can really see is that of the applicable supplies, the PPEs are only available in 66%. So that is a thing that should be really well, a point of attention to this network organization. Within the next slide, or the other slide part of the dashboard, you can see the input of the specific supplies and capabilities of all the facilities. So I now blinded them, of course, because I don't want the names there. But you can see here that, for example, where you see the red arrows, that the cleaning supplies of that particular healthcare facility are out of stock. So a healthcare organization or a network organization could contact those healthcare facilities and could say, hey, this is really something you should be improving, or how can I help you with that? And I can't, unfortunately, I can't show you everything, but there is a lot of detailed information, all the specific criteria of the supplies and the capabilities present in this dashboard. And of course, partner organizations can decide on how they're going to contact healthcare facilities. Some preliminary data insights. What you can see on average is that the general hospitals are performing a little bit better than the outpatient clinics. And as you can see here, these are the scores. So it's on a scale from 0 to 100. And that you can see that, so these groups are performing a little bit better. And especially on the processes, there's still room for improvement. So I think that is those learnings and specific from the dashboards can be used to improve the quality. What you can see here is some data about the location. What you can see is that urban facilities are performing a little bit better. There are less urban facilities, but they're performing better than their rural counterparts. And here we have some data on the availability of the PPEs. And you can see that for the medical masks and for the gloves, they're quite, the stock is quite well. Although you could also say 12% of the facilities do not have medical masks. And I think it's really something that we as SafeCare, but also network organizations or healthcare clinics themselves can see, hey, I don't have these stocks, what are the alternatives? What kind of masks can I use? And especially what you can see here with the respirators and the protective goggles, those are really, there's really a lack of supplies. What we can also see, but it's of course, I didn't want to show that here because it was too much detail, is that there are a lot of difference in stock between the different countries. So for example, Ghana is doing far better than other countries because they have a good, we can see for the healthcare facilities, we have data on that stock is better than in other countries. The last slide that I would like to show you is the information, the detailed information on the processes. And I highlighted here the criteria that apply to laboratory, and that's of which more than 20% of the facilities do not comply with. And of course, that's too often because an infection prevention policy that's absent in more than 50%. Maintenance is absent in almost 40%. So these are again learnings which we can take action on. So to conclude, I hope that with this presentation, I would like to invite you to use the app. You could use it in your organization, or you can send it to people you think might be interested. It's worldwide accessible. It's a free app, and we feel that content-wise we can really support healthcare facilities with that. Also, if you're interested in a personal dashboard, my contact address is below, so please contact me and we will be more than happy to provide you with this. I would really like to thank you for your attention, and if there are questions, I'm very happy to answer them. Thanks, Anafi.
Thank you, Afke, for the wonderful presentation. And I just want to remind you all that the link to the app has been put in the chat box, and we will also be sharing this together with the slides as well. Please keep the questions and comments coming through as we try to move on to the next presentation. I would like to call upon, I think, colleagues from SAVICS, Clement Prince Tuisabe and Hotia Venharen, hopefully I pronounced that one correctly, to give us the next presentation. Clement, are you there?
Yeah, hello, Anafi. Thank you so much for hosting this. And hello to everyone. I'm going to share my screen. Thank you, Anafi and the followers. So this is SAVICS, and we are presenting a tool called MediScout, which is an active case finding tool used in communities and report the data to the national dashboard using mobile applications by the community health workers. So as you know, as you might be aware of, SAVICS is a company that was established in Brussels since 2016. So we are operating in different African countries, 14 countries as of now, and in Asia as well as in Europe. So it's a company that is growing faster, and you have been involved in different development of solutions, including MediScout, as I said. So we do provide a range of solutions, including preventions, identifications, screenings, treatments, and follow-ups. So today we will be discussing, I'll be presenting about MediScout, which is an active case finding tool, as I said, and used by the community health workers to find the missing cases. So by developing this tool, we're trying to address the issues related with health systems, especially difficulties in targeting high-risk communities where we can focus screenings, and difficulties in disease monitoring and surveillance. So we try to understand how we can find the missing cases effectively and link them to the diagnosis for faster treatment and care. So our solution is a data-driven solutions, resource efficient, and it is a very effective approach for active case finding and contact tracing. So we use 3 steps in these approaches. So we first of all identify the communities using prediction maps. These communities are mostly the communities at high risk. And then we send in, the tool can send in, be used to send in the community health workers to collect data. And these data are used, are collected using a mobile application through estimating individual disease lists and enabling referrals, as I said, to health systems for care and treatment. So then the data will be sent at the national server, where the program managers will be accessing the dashboard on number 3 through web applications. This means that MediScout is made up of 2 applications. One is mobile applications, as I said, and another one is a web application. So how do we do by providing data-driven mapping? So the predictive maps that I used are based on algorithms. The predictive maps are based on algorithms that are applied to satellite images, and some of the data, such as open source data, including WHO incidences rates and national density and distribution data. Especially, for example, you might say also mining camps, health facilities, and so many others. So it can also be based on annual reports from the local health systems. Those are Ministry of Health or national programs. So once these high-risk zones have been identified, then community health workers will start by enrolling patients using a model of offline or online. And this can be done even in demanding contexts. Where these community health workers will start the disease risk assessment by administering some questionnaires that scores and risk satisfies these targeted populations in communities. So it is also provided and adjusted guidance where the risk can have some scores, and then these community health workers can be guided by the program managers to offer the patients care that seeking advices. So the questions might be, for example, for TB, based on some symptoms, like how long have you been coughing it for more than 2 weeks? Do you have an unexplained loss of weight? Are you sweating during night, or even some unexplained fatigue? So after this, then they will be able to report automatically in a synchronized manner to the national server, where through the web application, the program managers can plan and monitor these active case finding missions on these web applications, and then be able to perform an easy analysis of collected data that has a synchronized data in the synchronized manner, enormous on real time. So we can say that this tool has been piloted successfully in South Kivu in Congo, and we can say that since 2019, the objective was to improve the organizations and number of TB cases found via active case finding efforts in this province of South Kivu. So we can communicate these results after the pilot that more than 13,000 screenings have been performed by the community health workers, 25 trained community health workers, where medium to high risk patients were identified to microscopy tests in the nearby labs. So the tool has increased the number of found missing cases in those communities, where more than 10 times cases were found using this digital tool. So it has also increased the efficiency of community health workers. For example, the screenings, the community health workers could perform 3 times as many as screenings compared to before. So the pilot in South Kivu has the results that have been published in the International Scientific Journal of Europe, and we can say that the prediction map that that have been used have been able to locate to perform the location of screenings interventions, where, for example, we can testify that there was a strong correlation of predicted TB incidences rate, which has been confirmed by the TB positivity rate within the sampled population. So these confirmed the TB patients found in these areas, as I said, was 3 times higher in these zones. So also using the mobile applications, mobile predictions, the questionnaire can be used as a triage tool to confirm the TB cases that have been found. Only among the highest score within the questionnaire that was administered by the community health workers in the populations. So we also confirm that more than 11% TB positivity within the lab tests were found in high risk, in these high risk locations that have been identified by the maps. So the efficiency is the tool is that the approach is resource efficient. It allows efforts of high risk in high risk areas where they can use mobile-based triage. Through this mobile technology, the programs are assured that they can perform the fast surveys, automatic individualized TB risk scoring, and data safety, because data safety and quality is also key. Where the program managers are the ones that guide the program the community health workers. What the community health workers do only is to ask the questionnaires and then tick them as they provide the automatic scoring. So we can say that there have been 15 screenings less than that have been found in less than one case, and then less than 9 lab tests have been made to only identify 1 case. So we can say that this tool can be easily integrated with the laboratory. We have another laboratory connectivity tool, which is called Data2Care, and we are in the process of integrating this one to synchronize the data from the field with the laboratories. So for the COVID-19 use case, the triage tool can use it to evaluate the individual level of risks of COVID-19, especially in terms of self-reporting and tracing of COVID-19 cases, systematic screenings of at-high-risk groups, and then configure instructional messages to guide health workers' actions. So then we can also use our Data2Care to integrate all the data from the field with labs, where we can visualize all the data. For example, the number of cases by regions. This is an example of Belgium, and the number of cases over time by region. So we are currently, as I said, have installed different solutions in different countries, 14 in total, across Africa and especially Asia. And we are working with different partners, international organizations, including WHO, Global Fund, Stop TB, USAID, and so many others as well, CDC, and so many others. So that's it for me, and thank you so much.
Thank you very much, Clement, for the wonderful presentation, and it's great to see that a lot is already happening with the app as well. So I would like to call upon our third presenter, who's Dr. Haynes Shepherd from EdgeX, the CEO of EdgeX, to give us the last bit of the presentation, and he's going to talk about the node from EdgeX and connecting data and devices across the healthcare ecosystem. Over to you, Haynes.
Thank you, Anfi, and greetings to everyone, and thank you to ASLM for organizing this session and giving me the opportunity to present this new connectivity device. As you'll notice from the logos at the top, this system was co-developed by the Clinton Health Access Initiative and EdgeX, and I'll have a little more to say about that later. So as Anafi just said, the node is designed for connecting data and devices across the healthcare ecosystem. And so I want to talk just a bit about the origin of the node. As I said, this was co-developed with CHI, and CHI identified deficiencies in the landscape of available connectivity solutions, and they created a target product profile. And then CHI engaged a small group of Silicon Valley engineers to develop a device that would meet all the requirements of the TPP. And those Silicon Valley engineers evolved into what is now a small company, EdgeX. And the result of the co-development was the node, which I'll describe to you now. So the first question is, why do we need better connectivity? So as you all know, it's a programmatic necessity for COVID-19, but also for HIV, TB, malaria, and many other infectious diseases. To have good data from both centralized testing and point of care testing. And digitizing and automating data flows improves the flow of data and the timeliness of data, which improves patient care, the time from diagnosis to reporting to treatment. It also facilitates central planning and monitoring and evaluation activities when data from all points in the healthcare ecosystem get transferred on a timely basis. Most connectivity solutions don't combine both data aggregation, data transmission with data display and remote monitoring. So that was a big objective in developing the node. And most solutions are also tied to a single diagnostic device or manufacturer. And this results in facilities having to purchase and maintain multiple connectivity solutions, which gets expensive. And we've also seen that effective support for installation, service, maintenance, and analysis has been a problem in some connectivity solutions. So the node is a versatile open source wireless device that enables primary healthcare providers to collect, aggregate, store, view, and share diagnostic results, both locally and centrally. And it also can collect just about any kind of critical patient data. And as I said before, unlike similar solutions, the node pairs with devices of all kinds and with multiple devices simultaneously. And it doesn't rely on stable internet connectivity, and I'll mention that or talk about that a little more in a few minutes. So what were the enabling technologies? Well, we started with low-cost, reliable consumer electronics, namely the hardware of a modern smartphone. And we use custom and open source software. And then, of course, it communicates via low-cost cellular data services. So the core of the node is a combination of both the Android and the Linux operating systems. And this is key because it allows the node, which might appear to be a smartphone, to be essentially a general computing device. And allows us to install server software, a relational database, smart router software, and then the key is interoperable code so that all of these things can work together and be presented to the user in a graphical user interface. The features of the node is that it can do secure collection, storage, and transfer of data from any diagnostic platform to any online server. So databases, dashboards, we're essentially just moving data and can move it to wherever it needs to be. We use secure wireless connections to multiple devices simultaneously. So there is essentially no theoretical limit on the number of devices that can be reporting their data through the node. And we've worked with a number of different device manufacturers, which I'll go over a little later. Now, because of the combination of Android and Linux, the node is a local server. It's a wireless hotspot, a Wi-Fi hotspot. It's a smart router. It's a user interface and can do data display as well. And because it's a server, the software and all the resources that are on the node are accessible from any device in the facility that has a browser. So a smartphone, a tablet, a PC can all access the node simply by opening a browser and then accessing the node's resources. Of course, we use asynchronous cellular connections to ensure complete reporting, even in unstable environments. So the system will hold data in its database until there's an available bandwidth and then send. We can also do external notification by SMS or email to send information to providers as well as sending it to central databases. And this ensures complete reporting and better linkage to treatment and better patient outcomes. We've also developed fully remote installation, configuration, maintenance, backup, and restoration. We can essentially do everything the node needs remotely. Our software engineers can access it from just about anywhere. And then finally, it includes a locked enclosure for and wall-mounted enclosure for additional safety and security. So we have already connected a range of instruments and tests, and the list is constantly growing. Because the node is instrument agnostic, we can connect it to a variety of instruments that many of which can run a variety of different tests. So you see a list of tests on the left and a list of instruments further to the right, the Gene Expert, BD Fax Presto, Abbott M2000, the new Lumira. All of these are quite capable of being connected to the node to deliver their data to the node in what we call the short link, which is the internal facility Wi-Fi link created by the node that transfers the data from all of these devices into the node. So how does it work in general? So as I mentioned, multiple device sources, diagnostic instruments, web forms, patient forms, photos, all of these can be stored on the node and accessed from anywhere in the facility. And the connections, as you see down here, are generally Wi-Fi because the node creates a Wi-Fi hotspot, but we can also do Bluetooth. So RDTs can be reported through a simple web form or a more complicated application. Diagnostic instruments, clinical forms, and so forth, all goes into the node and becomes structured data in a relational database, which allows not only structuring and transfer of this data to central web servers, but also allows access and visualization at the local site by local providers to see the data generated in their own facility. And then the data uploads automatically whenever there's bandwidth available and can go to either a local or national web server or in the cloud, although many countries prefer that it not go into the cloud, patient data not be on the internet, and that's fine. We just use local servers. And then national databases, we can interface with LIMS, or we can interface with EMRs as well. And we have made connections to DHIS2. And then again, as I mentioned earlier, in addition to this flow of data from data sources through the node to databases elsewhere, we can also generate notification messages that can go to people by email, SMS, or voice. So we go from data collection to data aggregation and analysis to structured data going into the ecosystem. So what is our data philosophy? It's simple. All data belongs to the country where we're working. Data storage can be and generally is local, or it can be in the cloud if there are no sensitivities about that, which we certainly recognize. Patient forms and dashboards are customized. Generally, we try to match existing forms and systems rather than create our own that may not be exactly what the country needs or wants. And we want to match the existing workflow so that there doesn't have to be a lot of retraining. In terms of data visualizations, we like Tableau because making new dashboards and ways to visualize the data is quite easy in Tableau. But as I said, we've also moved data into DHIS2 where countries already are using that for their data visualization. And other popular data visualization platforms can easily be customized to accept our data or analyze the data the way it's already being done. So here's just one quick example of a dashboard. This is HIV data from Kenya with a test per day, errors, average time from the instrument to the NASCOP, which is the central data server in Kenya, and some metrics about the utilization of the instrument. In addition to transferring data, the node also continuously transfers status information, both about itself, whether it's on and has a good cellular connection, what instruments it's connected to, and it also continuously monitors the status of the diagnostic instruments that are reporting data to it. So we can also look at that kind of information on the dashboard, and it notifies us when there's a problem so that we can immediately provide support to maintain continuous connectivity. So finally, very quickly, we've been working primarily in Kenya. Most recently, we've connected a number of gene experts, Abbott M2000. We're currently working on Roche, Hologic, and Lumira as soon as those instruments arrive in country. And so it won't be long before we'll be collecting data from those platforms as well. We have some installations in Ethiopia as well, primarily the BD Fax Presto. But we're also about to work on demonstrating connections to the Abbott M2000 in Ethiopia and again the Lumira antigen instrument for COVID-19 as soon as those instruments get into the country and installed. Now, as I mentioned at the very beginning, this was really a co-development with the Clinton Health Access Initiative, and so there are a number of other countries that have CHI offices and active programs for COVID-19, and we will be discussing the potential of the node in all of these countries in the near future. So that's it for me, and I'll be happy to take any questions in the short term or in the longer discussion at the end. Thank you very much for your attention and the opportunity to tell you about this general connectivity solution. Thank you.
Thank you, Haynes, for the wonderful presentation. Interesting insights indeed. So now we are moving into our question and answer segment. So keep the questions coming. As we are about to get into the questions, so today let me just take advantage and be the first to ask all of you the three questions. The SafeCare app, MedScout, and the node. Interesting innovations indeed. We have had challenges, or should I call maybe sort of barriers when it comes to interfacing diagnostics or whatever health technologies that we have in our systems, particularly when manufacturers require some form of payment, some form of user fees, license to connect these. Well, what's the case with all these three? Maybe let me start with you, Haynes, since you are on the stage.
Sure. So we don't charge for, we charge for the node originally, and we develop a service contract, but after that, we don't charge individually for connections to a new instrument or any other fees that relate to connectivity of the node to instruments or delivery of data to web servers.
All right. Thank you very much. Afke, you want to take? You're on mute.
Yeah. So we developed this app to really support healthcare providers and other stakeholders, and we developed it already. So it's a free app. There's no license fee. If for example, for ministry, we would need to customize it very much. That would, of course, maybe have additional cost, but usually we can cover that under our, until now, we have covered all the costs ourselves.
Great. Thank you. Let me call upon Clement and the colleague.
Thank you, Anafi. Thank you so much. In terms of interfacing with other existing systems, yes, we have APIs that can enable this, but using it as a standalone application, yes, of course, there is a cost behind it. However, it's something that is not, I cannot say comfortable, or I would not say, I would say that it's something that we discuss with countries and try to understand what are their needs. But what will be the prime requirements is that they have to have these smartphones. They can buy themselves, or we can support them in buying them. So they have to have a server. If they don't have, then we can also support them to. We can buy it. However, we cannot say that those associated costs will be paid only by SAVICS, but rather between us and the partner and the potential partner. So it is something that we can discuss case by case with the end users, especially the program managers. Yeah.
All right, thank you, Clement. Taking the next question, I think it was around availability on the app store. If I got that correctly, are these apps available? The app for SafeCare for COVID is not available in the App Store of iPhone. Why? What is wrong?
We want it to be accessible by everybody who has access to internet. So that's why we decided to develop it as a progressive web app. And that means that when you have access to internet, you can access the app and you can put it on your home screen of your mobile phone. So that's a question that you will have when you register. So you can use it really as an app, but it's accessible not only via the App Store. So with its downloading, we thought we would reach the biggest audience.
All right. Well, whilst you are there, Afke, is the SafeCare able to speak to DHIS2? This is from Albert Musinguzi.
Well, we have been discussing that with especially ministries, because of course that is, we can make a link, but we at this stage, because it's of course it's now a general app, we didn't do that yet, but we can let it communicate to make that link with a particular facility so that it's easily to work with for ministries, for example.
Okay, thank you very much. Another interesting question that came from, the name is not very clear, but what sort of support is provided to the users for this? Let me start with Haynes for using this app.
Yeah, we provide full support. The first year after the purchase of a node is free, And then there is a support fee that's starts around $1 a day that provides full support and backup. So any problem that arises with the node itself, but also problems that arise with the diagnostic instrument, to the extent that we're able to address those. I mean, there's certain things that you can't do without the manufacturer's assistance or permission, but anything that we can do, we will do as part of support. So we keep the nodes up and running. We keep an eye on whether they're transferring data to the central servers where they're supposed to go. We do occasional updates, which can be done remotely. We monitor that the system is running as it's supposed to run, and all of that's included.
Thank you once again, Haynes. Clement, what sort of support do we give with the MedScout?
Thank you so much, Anafi. So the support is based, I can say that on the cost also, but I would say that we have different packages which can range from 11,000 to 150, depending on the usages. As I said, if the users are many, I can say that the support can be high. But again, this is also related to the number of data they are collecting. If the data is too much, so then so the cost also can be somehow high. But I would say that what we provide at the beginning is in terms of training the national teams on how they can also transfer the same technology to the community health workers and some other users, be it volunteers in some countries. Then we provide that training, be it remotely or even in countries, so physically. So that is something we always do. And we have done this in our experience because we went to Congo, and we are going to scale up in Congo. We will pilot it in Rwanda, hopefully next year. And yeah, it's something that is really working.
Thank you. Yeah, moving on. Afke, you want to take that one?
The same question, the support?
Yeah.
So until now, of course, we did a lot of testing, and there were, of course, comments coming back with technical support, and that has been really a nice learning experience. So that we developed the app that that it can be used on various mobile phones. So until now, if there is a problem or a technical problem, you can contact us via the contact form. And healthcare organizations, of course, that are using it can contact us, so that we have a technical team that can support the usage. But the latest month, that hasn't been necessary.
Okay, all right, interesting.
Could I just make one quick comment?
Well, go ahead, James.
So for web applications like SafeCare and many others, those could actually be hosted on the node because it is a server. So that would, to make web apps like that available without an internet connection within the facility. Of course, that would be, wouldn't be possible with an app that you're going to use in the field. But any app or web app that's used within a facility could be hosted on the node, eliminating the need for bandwidth.
Oh, interesting. Yeah, that also comes to two questions that I saw. One was from, I think it was IATNU, asking about the use offline. And it's interesting that you have touched the issue of bandwidth, which is usually a common challenge. So maybe a comment from there, the ability to use offline app, or maybe, yeah, you mentioned bandwidth.
Well, I'll go ahead and answer that since I'm already on. Yeah, all the resources of the node are available offline. The only time it needs to be online is when it's going to send data to another server somewhere. And that's done with the typical what's called asynchronous communication features of Android, which means if it has data that's flagged to be sent, it will just sit there and keep waiting for any available bandwidth and send the data as soon as there's any bandwidth available.
Yeah, interesting. Yeah, thank you. I'm seeing a question from Tafuma Zanamwe from Eswatini. And it's a relevant one indeed, where he's asking about the possibility of having local installations in country. I say so because many a time there's been challenges in trying to convince ministries of health to host these applications, particularly with the issue on where the data is going to be hosted. So I think interesting insight indeed. What's your take? Let me start with Clement. Options of hosting locally.
Thank you. Thank you so much. So SAVICS being a European-based company, so we respect the data privacy and confidentiality in the GDPR 2018 of Europe. So we don't interfere into the management of the data. We provide the national teams with the application. Then they are able to manage themselves the data. We only intervene when, for example, they have a problem with the server, some of the critical settings that might not transfer the data from the field to the national server. So that's where we only can provide support. Otherwise, other things are very easy for them to manage from the program management through MediScout Web, based on the training that we have provided to them. So maybe if she's trying to understand about the scale, the rollout. So the application is available, as I said, on Android, and it is on demand. It's available on demand. So anytime they can have it, and then maybe training the national teams can only take like 1 month, and they are ready to go and they start collecting data.
Yes, but I think his question also was on whether there's an option to host the data or to have the servers in country as opposed to elsewhere. Is Zanamwe online? Let me just try to see if he's able to further expatiate on that. Hopefully I did not hijack his question. Tafuma, are you there?
Yes, I'm there, Nafi. So my question is basically on that aspect of hosting the server locally and then hosting the data locally. So I think from what he has said, has said that it is possible. But since I got this opportunity, maybe is to say, roughly how long does this take to do the deployment and so on?
Thank you. Thank you, Tafuma. On roughly how long does it take? Let me also combine that question with one from Pascal, and it was also directed to AFCE, but I think it's all about timelines. I know AFCE, you have responded to this, but for the benefit of everyone online, Pascal had asked, after how long would you reapply the assessment to the facility and monitor progress towards the COVID-19 response preparedness? Is there a quality improvement guidance within the tool, or is improvement relying on external interventions?
Yeah, thanks for the question. That's also, of course, you can do it in different ways. Healthcare providers can decide themselves after how long they are going to reassess themselves. But we are in projects doing it after 3 weeks, because after 3 weeks, the facilities have had already the time to improve. And you can really monitor if the score is going up. If you about your question about the quality improvement guidance, there are 2 parts: assessment part and a checklist part, and there is quality improvement guidance. And there's really, I know the demo went went very fast, but you could see for every criteria you would have like a lot of action points that are really practical and are really guidance to help those facilities improve. And as well, to combine that with the offline question, you could print out those quality improvement plans and distribute it, for example, in your healthcare facility, or use it to put it on the wall, so that also offline you can use the learnings from the app. So that's my response to Pascal. Anna-Fie, shall I also answer to the question about the data and if that's possible to host that in country?
Yes. Please go ahead.
So it is. We have two options. You use the app as it is, and then you have access to the dashboards that are centrally distributed for the particular organizations. If you would want to, everybody of course owns their own data, so it's not that SafeCare is owning data. It's the data of the healthcare facilities, is the data of the countries. If there's a specific request that the data should be in the country or in the cloud in the country, that could be also, then it's just a separate tool, then we just make a copy of the tool and then it can be hosted and owned locally. This is really for the customized tools for ministries, for example.
Thank you, Afke. Moving on, I think it's still around the same issue of owning the data. Let's assume I'm a program manager and a director of laboratory services. How do I get this up? How do I approach you guys to get this? Let me start with Clement.
Yeah, thank you, Anna-Fie. I didn't hear the question is from.
Yes, we know this is on the app, right? But what I wanted to find out, is this something that I just get on an individual level? But imagine I'm a program manager. I want this to support my system in general. How do I formalize this and pick it up? I'm picking this from Oswald Samje, where he's asking, how can MOH request this training? Like MOH in Cameroon. And he has also asked about trainings coming through.
Okay, thank you so much for you, Anna-Fie, and thanks also to Oswald. So it is not complicated. It's just a matter of reaching out to me, and I will let him know some of the formalities that are required to formalize this his request, his or her request, his request. So we can also, as I said, after this, it's simply an agreement that is signed between us and them as the Minister of Health. Then we will be able to provide, even in 1 month, we can start the training of users. So we normally train the national programs, and then the national programs can deliver the same knowledge, transfer the same knowledge to the communities, to the community health workers especially, or volunteers if that's what they use in the country.
Great. Thanks a lot, Clement. Hence, if we want to say adopt the use of the node, how do we go about it?
You just contact us and purchase a node, and then we can, as I said, we can do completely remote installations. So we simply would have to get supply of nodes into the country, move them to the local facilities via local courier, and then we ask facilities to install a simple piece of software that allows remote access to the node, and then our software engineers do all of the installation, configuration, and maintenance after that.
Great. Afke?
Yeah, the app is there, so it depends on the time, the customizability that you want. So I think that's the way to Anafi, I just of course we sent a presentation. I send a new one to you with my contact on that as well. And people can contact me and we can set it in motion right after. If it's not customizable, it can be started next week or tomorrow even. And otherwise, it just depends on the customizability that it's needed for example, a Ministry of Health. That will take a few weeks, something like that.
Great. Thank you. Indeed, we will be able to share, I think, all these resources. There is a question from Casimona Sichela. This is quite rather technical. So I hope as you also respond, you can also explain to us what this means. He or she says, is the code base for the node publicly available? Is the technology tied to the node device, or standard PCs can be used as well? So maybe you can also help us expatiate what code base and everything else means.
Yeah, as I said, most of the software we use, the individual bits of software are open source, but the code for the merger of Android and Linux and the interoperability of that and our user interface are not code that's generally downloadable at the moment. And again, this couldn't be run, the node functions couldn't be run on a PC per se, because we depend a lot on features of Android operating systems. So the asynchronous cellular communication and a variety of other capabilities of the node really depend heavily on this combination of Android and Linux. And for that reason, it basically has to be smartphone hardware. And yeah, the individual bits like the server software are open source, but the entire combination of software elements that make the node are not currently publicly available.
Great. Thank you very much, Heinz. There's I think this is Nuagira who says, please help me with the names. Looks like I think these names are a little bit unique. So I think we are talking about the node here from EdgeX, and we also are talking about the MedScout from SAVICS, as well as the SafeCare for SafeCare app for COVID from SafeCare. I think we have touched most of the questions. Hopefully we haven't left out any. If there is, please feel free to raise your hand here at this moment. Whilst we are doing so, I just want to ask Afke to give in 1 minute just some summarizing remarks.
Yeah, thank you, Anafi. Well, I have been very honored to discuss here today the SafeCare for COVID app, which is freely available for healthcare organizations, healthcare facilities, and network organizations to be used within their facility or within their network, which will provide practical advice and tools to help healthcare facilities or be empowered to care for COVID-19 patients, and also to get their quality processes in place to care for non-COVID cases. I think the advantage of our tool is that it really makes data transparent to be used on multiple ends. And well, I would be, I hope that many facilities will use it and get further prepared to manage COVID-19 patients. Thank you.
Thank you, Afke. Clement.
Thank you so much, Hanafi. So it has been an honor and a great pleasure also to share this experience of Mediscout with the people that were present, and I really thank them. So Mediscout is ready to be used, as I said, and already some people are using it now as we are talking. And another thing is that it is an easily customizable tool, flexible to to multiple diseases. It is not only that we piloted it in Congo under TB, but it can easily go to COVID-19. It can go for HIV and some other interventions, such as collection of malnutrition or child, maternal and child healthcare issues, and so many other initiatives that programs can have in place. So they are really welcome to reach out to me or to reach out to SAVICS. So it's very simple. You can click in Google and you will easily see who SAVICS is. And then you can approach us without delay. Yeah, thank you so much.
Thank you very much, Clement, once again. Haynes, in 1 minute, any key words, remarks?
Yes, I'd just like to echo Afke's and Clement's appreciation for the opportunity to make this presentation. And we really think that the node has the capability of being a game changer in terms of moving all sources of healthcare data through the healthcare ecosystem, from the locations where that data is generated, through local visibility of the data to the users in the facility, to national databases where it can be used to monitor and optimize the national healthcare systems. And so again, thank you very much, and appreciate the opportunity.
Great. Thank you very much. Indeed, we need these local innovative solutions to curb the impact that we are having from COVID-19. But not only COVID-19, but we are also happy that these are also applicable to existing public health problems that we have, particularly in resource-limited settings that many of us are staying in. Also interesting to have learned that most of these are open source. We have also heard that some of them are linked to wireless devices that are able to collect data, aggregate it, store it. There are also web forms. Also interesting to note that there are also some options for offline access to data. And also thanks to Clement for sharing some of the lessons that we have learned from the DRC. And also, we are also excited to see that there is also interest in really covering more areas in this. So we're hoping that after some time, we actually having data from other countries as well to share on this platform. And we're excited to have such innovations coming through, and particularly if they are applicable to COVID-19 right now, since we are having many of these interventions coming through. And if we are able to manage this data, it will inform how we respond to the pandemic. We will be continuing as usual with these sessions, and watch out for our next session that is coming through. We should be able to advertise that very soon, and we always appreciate you coming in numbers, and we should be able to share with you the recordings of this session together with the slides, particularly in a day or two. For those that need to go to our ASLM Academy page, you are able to go there and access these sessions and those ones that we have had previously. There you will also be able to download your certificates. Today we don't have the certificate code immediately available, but this should be sent to you together with the slides. With this, I would like to say good morning, good afternoon, and good evening till we meet again. Thanks and bye-bye.
Thank you. Bye.
Thank you.
Thank you. Goodbye.
Bye-bye.